Thanks very much, Rob. So the syndrome is called Lynch syndrome. Just a few years ago, it was called HNPCC for hereditary non-polyposis colon cancer. But once it became quite apparent with more research that the syndrome is not restricted to, it doesn't just cause colon cancer, but many other cancers. In fact, some of the other cancers are more serious, are even more common in some families, and is much less understood. So it's my pleasure to introduce Dr. Jeff Spodek, who's the Chief of Urology at the Ruby Valley Health System, who's going to speak about the urologic aspects of the Lynch syndrome.
Thank you so much for inviting me to speak with you tonight about a topic that I must admit I did not know a whole lot about 5 years ago or even 2 years ago. You may be wondering how a urologist from Scarborough gets to speak at Mount Sinai. And I'd like to thank Melissa Aronson for inviting me to share with you my experience and go over some of the screening studies that have been done for urinary tract cancers. So this is essentially what I treat. I treat the kidneys, I treat ureter, I treat bladder, prostate will be sitting in front, and I treat the urethra. And it's important to understand that tonight we're talking about urothelial tumors. And urothelial tumors are not your typical kidney cancers. So if you look more closely at the kidney, you have the meat of the kidney, and that's where kidney cancers tend to occur. Those are called renal cell carcinomas. But that's not what happens in Lynch syndrome. In Lynch syndrome, there's an increased risk of developing cancer of the urothelial tract. So that's the lining, the cells that line the renal pelvis, the ureter, and then go all the way down into the bladder. And if we look at the epidemiology of urothelial tumors, they're actually very rare in Western countries. The annual estimated incidence is only 1 or 2 cases per 100,000. And typical risk factors for these individuals would be age, so typically older individuals, 50 to 80 years. There is a male predisposition, 3 to 1. Individuals from the Balkan countries are predisposed to developing some kind of kidney disease, and for some reason this leads to an increased risk in urothelial tumors. Smoking is probably the number one cause, and it's the number one cause of bladder cancer in general. Bladder cancer and urothelial tumors of the renal pelvis and ureter are the same type of cancer. So a lot of people associate smoking with lung cancers. But there's one thing you can take home from tonight and tell your family and friends is smoking also causes bladder cancer, and it's best to speak to your family doctor about stopping smoking. Other risk factors, phenacetin is an analgesic drug that really isn't used much in North America, but if you tend to take a lot of it, you develop a kidney failure and increased risk of urothelial cancers. There are some occupational factors, and then finally hereditary or Lynch syndrome. So in terms of Lynch syndrome and transitional cell cancers or urothelial cancers, the lifetime risk ranges from very low, 0.2%, up to 25%. And it really depends on which studies you've looked at and which urinary tract cancers are included. I think kidney cancers are lumped in with urothelial tract cancers in a lot of the studies. But we're mainly talking about the risk of upper urinary tract cancer, renal pelvis, and ureter. The highest risk is in patients that have the MSH2 mutation, especially if you're a male and you're over the age of 50 to 70 years. Typically, if you have this mutation, it's a younger age of onset. It may be 10 to 15 years earlier than the average population. And we know that there are some familial clusters of urinary tract cancers. So how do these cancers typically present to my office? I would say that the most common would be someone has microscopic hematuria, microscopic blood in the urine. And this would be something that would be picked up at the family doctor's office. Sometimes you may see blood in the urine, so the urine is red or discolored. You may have pain in the flank and the sides, and typically if that happens, there's a blockage or an obstruction of the urinary tract. However, up to 10 to 15 have no symptoms whatsoever. In terms of the investigations, these are the investigations that we typically use to investigate blood in the urine. So we would start off by doing a simple urinalysis, and this is something that your family doctors can do. They can also order urine cytology, so that's looking at the cells from the urinary tract under a microscope. I can look in your bladder, something called a cystoscopy. I can inject some dye up the urinary tract, and I'll show you pictures of this as we go on. I can actually look up into the kidney, something called a ureteroscopy. We can do ultrasounds, CTs, and MRIs. So I'm going to talk a little bit about each of these tests, what are their limitations, and then we'll get into screening. So in terms of detection, the simplest test, and a test that all of your family doctors do, is a urinary dipstick test. And in this case, we're looking for blood in the urine. And the test is either positive, there is blood, or there isn't. Now, there are some false positives, none of which you need to be concerned about. But if your family doctor finds microscopic blood in the urine on a dipstick, then that urine is always sent to the lab to be looked at under the microscope to confirm that there is blood present. And if there is, you'll usually then be referred to a urologist for further investigation. So what's the problem of using urinalysis as a screening test? Well, the main reason is that it's not specific to urinary tract cancers. There's lots of other conditions that can cause blood in the urine, including kidney stones, kidney infections, inflammation of the urinary tract, including prostate disorders as well. So it's not specific to urinary tract cancers. What about urine cytology? So as I mentioned, the pathologists look at the cells under a microscope, and they tell us, do the cells look normal? Do they look abnormal for a diagnosis of cancer, or are they somewhere in between? And there's two ways that we can get urine. One is by having you pee it out, and the other is by taking it directly either from the bladder or from either kidney. And that's something that I would do in the operating room. The problem with cytology is it really depends on the expertise of the person looking at it under the microscope, and it also depends on the stage and the grade of bladder cancer. So what that means, cytology is very good at picking up aggressive urothelial tract cancers, but it's not very good at picking up your run-of-the-mill, early-stage, low-grade, non-aggressive cancers. So that's why it's not a great screening test. If the cytology comes back positive for cancer cells, it's virtually diagnostic of a urothelial tract cancer. And then it's up to the urologist to find out where it's coming from. Is it coming from the renal pelvis, or the proximal ureter, or the bladder? If it's negative, well, it's less helpful. It tells us you probably don't have a very aggressive cancer, but you still might have this low-grade, early-stage cancers. And a lot of the times it comes back as atypical. So the pathologists aren't sure. The cells don't look normal, but they don't look abnormal enough for a diagnosis of cancer. And then the question is, what do you do with that? Usually it leads to further investigations, but only 15% of those patients would have underlying urinary tract malignancy. So the limitation of just using this test alone is that it's not very sensitive at picking up cancers, and there's a lot of false positives. So a third way that we look for urinary tract cancer is called a cystoscopy. So this is probably the most common procedure that I do. I typically do about 50 of these a week. And it allows complete visualization of the bladder, lining, and the urethra. There's two types of scopes that can be done. So this is an example of a flexible cystoscope, which is introduced into the urethra under a local anesthetic, so some Parisian jelly, and we have a look in the bladder. Well, what's the problem of using this as a screening procedure? Obviously, it's an invasive test. There is some patient discomfort. There's a small risk of developing a urinary tract infection, so small that we actually do not treat with antibiotics before or after. And it is fairly expensive if you roll it out as a screening procedure. So what are we looking for? These are 4 examples of what early stage bladder or urothelial cancers would look like. So they're very vascular. There's a lot of blood supply to these, and that's why you typically see either microscopic or visible blood in the urine. I mentioned that I can inject some dye up the urinary tract. So if we remember the first picture I showed you, imagine this is the kidney. So up here is the meat of the kidney, and then this is the renal pelvis and ureter. And what I've done is passed the scope into the bladder and then injected some dye up into the kidney. And we can see that there's an abnormality here, a fairly large abnormality, and it would correspond to something like this. This is what we call a filling defect. So there's something...
Attention all visitors. Visiting hours have now ended and you're requested to please leave immediately. Attention all visitors. Visiting hours have now ended and you're requested to please leave immediately. Thank you and good night.
So this would be a large tumor that occupies most of the lining of the kidney. So let's move on to the other tests. There's 3 other imaging modalities with ultrasound. Ultrasound is really good for looking at kidney cysts and looking to see if there are kidney cancers or renal cell carcinomas, but it's not very accurate for diagnosing small urinary tract cancers, especially in the renal pelvis and ureter. The advantage of ultrasound, however, is that it's not an invasive test and there's no exposure to radiation. So a very simple test done. CT scan is probably the best test for looking at solid renal masses, so looking for the renal cell carcinomas, looking for kidney stones and infection. If you're going to look for a urothelial tract cancer, it involves 3 stages. So the first stage would be a non-contrast CT scan. You lie flat on the table and x-rays are taken. Contrast then gets injected through a vein, and contrast gets filtered by the kidneys. And then you take a delayed film where that contrast is now in the collecting system and you're looking for those filling defects. The problem is that very small tumors may not be seen even with a CT scan, and the limitation in screening is that there is a risk of radiation exposure, especially if you have repeated studies, and the risk of radiation could potentially lead to development of subsequent cancers if you have enough CT scans done. So this is a CT image. This would be normal looking left kidney, and the white is that contrast that gets filtered into the urinary tract, into the renal pelvis. And if we compare it to the right side, so the light gray is a normal looking kidney, and this dark gray area would be a cancer of the renal pelvis. What about MRI? MRI is actually almost as good as CT scan in looking at renal masses, but it is more expensive. There is limited availability, and usually we use it as a second or third line approach after an ultrasound and the CT, and if there's still some questions as to what's going on. So in terms of treatment, the treatment really depends on the location of the cancer. And we divide it into the renal pelvis and upper ureter. So if we go back to this slide, so the renal pelvis and upper ureter, the standard treatment is called a radical nephroureterectomy. So that means that we remove the entire kidney, the entire ureter, and we have to open up the bladder and remove even this part of the ureter that goes into the bladder. So it's a big procedure. It can be done laparoscopically, so minimally invasive, keyhole surgery, so the length of stays and the recoveries are a lot faster. But it is a big deal type of surgery. If you have only one kidney, and we obviously can't remove that because of a risk of needing dialysis, then there are other options, but these are very rarely used. Sometimes we can use a laser to vaporize the tumor, or we can scrape out the tumor by going in through the back. But that's not standard of care. If the tumor is in the mid-ureter, so somewhere between here and here, then we would remove that piece of ureter and sew the two ends back together. The problem in doing that surgery is that there's a high risk that the joint site of the ureter narrows down, and that can lead to increased problems in the future. So I've been in practice for 12 years, and I've never done a segmental resection of the ureter. If it's in the distal ureter, which we see most commonly not associated with Lynch syndrome, we can remove that part of the ureter, and then we can reattach the end into the bladder. So a lot of more options if it's in the lower part of the ureter. So the last part of my talk, we're going to talk about screening, and screening in particular for Lynch syndrome. In general, if you're going to introduce a screening test to the population, you have to make sure that the disease is common and there's high morbidity and mortality. So a lot of people will have problems from that disease. There's a high mortality rate. You have to have treatment modalities that are acceptable, safe, and relatively inexpensive. And you have to make sure that you diagnose as many people as possible that have the disease, and as few as possible without the disease should be subject to further investigation. So really what it means is you want to find all those people that have cancers, and you want to make sure that you don't investigate or treat people that don't have cancers. And finally, there has to be a high likelihood of a positive screening will give you a correct result. So you diagnose correctly those people that have cancer. So what about screening for bladder cancer? Studies over the years have shown that it has not been effective if you use urinalysis and cytology for microscopic hematuria in the general population, and even in patients that are at high risk for bladder cancer because of environmental factors. And firefighters would be the highest group of environmental exposure. Studies have looked at screening firefighters for urinary tract cancers, and it has not shown to be an effective screening procedure. In terms of ultrasound and used as a screening, we don't know what the benefits are for bladder cancer. In terms of Lynch syndrome, there are only 2 studies that have actually been done looking at systematic screening. There was a study in Denmark that looked at urine cytology, and in the study, the sensitivity of diagnosing an asymptomatic urinary tract cancer was only 29%, and only 0.1% of all the urine cytologies led to a detection of an asymptomatic cancer. There was a high false positive, which meant that you thought the patient had cancer, but upon further testing, they did not. And the conclusion from the study was that cytology was not an appropriate screening method. There was a second study that looked at cytology, doing a biannual cystoscopy and one initial CT scan. And again, the conclusion was the evidence for systematically screening in Lynch syndrome is lacking, and there's a need for further investigation to find not only the optimal screening method, but also which population do you offer screening to. So, bottom line is neither of the study was able to answer the question of whether screening for urinary tract cancer or Lynch syndrome is recommendable, and there's no standard screening recommendations being established internationally. I came across a couple of options. This group, the Mallorca group, found that if there were 2 or more cases of urinary tract cancer in a family, so there was that familial cluster, that you should probably have a urinalysis and a urine cytology, and you should probably have at least an annual ultrasound starting at a pretty young age, age 30 to 35. And it sort of makes sense. These are pretty simple, non-invasive tests, relatively inexpensive. There's another way to look at it. It's the risk stratification. So if there's a low risk, meaning there's no personal or family history of urinary tract cancer and no MSH2 mutation, then you offer an annual urinalysis and cytology. If there's intermediate risk, so there is a family history, then in addition to the urinalysis and cytology, add an ultrasound. And if there is a high risk, there's a personal history of urinary tract cancer, then you offer everything: urinalysis, cytology, cystoscopy, and CT scan. So what's done here at the Mount Sinai Hospital Genetic Clinic? I quote, there are non-invasive screenings such as urinalysis and urine cytology, but it's been known to miss cancers or may falsely identify problems that can lead to more invasive and unnecessary procedures. More invasive screening such as cystoscopy is not routinely recommended for Lynch syndrome families, and the recommendations are not evidence-based or known to be completely effective, but we would suggest that you speak to your family doctor about doing an annual urinalysis and urine cytology using 2 different urine samples. And obviously these recommendations may change in the future as more studies come to light. So if I was a patient with Lynch syndrome, I would probably undergo an annual urinalysis and cytology, especially if I had the MSH2 mutation in a male. And I would probably have an annual ultrasound done as well, because it's a relatively cheap, inexpensive test with little risk to you.